Neural tube defects represent failure of the neural tube closure between the third and the fourth weeks of gestation. This may be affected by many periconceptional factors, and prenatal screening with alpha-fetoprotein levels at 16 to 18 weeks frequently will show an increased level. Spina bifida occulta is a midline opening of the posterior rami of the vertebrae without any protrusion of neural tissue. The most common place is at L5 to S1, and most are asymptomatic, unless uncommonly they are associated with more serious defects. A clue to the diagnosis is any lumbosacral midline cutaneous defect. In general, the more severe the defect, the more severe the underlying anomaly. With abnormal neurodevelopment, that is an abnormal neurological exam and an abnormal gross motor exam with respect to the lower extremities, we always have to be concerned about the possibility of what is called a tethered cord. Occult spinal dysraphism with this is indicated by, again, an overlying cutaneous defect. The highest risk is with a caudal appendage, that is a tail, a dermal sinus above the gluteal folds, and with lipoma. If these are present, and if there is an abnormality in the gross development or in the neurological examination, then the best test should be performed, and that's a lower spine MRI. So the definition of a tethered cord is that there's a persistence of a thick rope-like filum terminale which anchors the conus at or below the level of L2. This then produces abnormal tension that leads to decreased blood supply, and with growth the spinal cord is stretched and we have abnormal neurodevelopment, abnormal neurological exam with respect to the lower extremities. Other anomalies in these infants may also be present. They may present with asymmetric lower extremity growth, which is seen as asymmetry of the gluteal folds, other deformations, muscle wasting, and particularly delay in crawling and walking, and then, if they are able to, toe walking and regression of lower extremity function becomes evident. Because these are low lesions, bowel and bladder dysfunction may be apparent as well. If this is missed, or if there are milder cases, older children will have a diffuse lower extremity pain. Again, the MRI will show the defect. Surgical transection is curative, and physical therapy may be needed postoperatively. A meningocele is a defect where the meninges only protrude through posterior vertebral defect. The cord is normal and there is no protrusion of neurological tissue. These are usually covered by skin, so it looks like there's a fluid-filled fluctuant mass that transilluminates positively. An MRI, as usual, is needed to evaluate for the presence of any neural tissue and for the extent of the lesion. A head CT scan is also performed because of the possibility of associated hydrocephalus. And a urological evaluation often needs to be done for bladder dysfunction and bowel dysfunction. The treatment is surgical closure. Whereas a meningomyelocele, or a myelomeningocele, can be said either way, is protrusion of neural tissue through posterior midline vertebral defects anywhere along the neuraxis, and most are lumbosacral. So that if we have low sacral lesions only, then we will basically see bowel and bladder involvement. With mid-lumbar lesions, you also get flaccid paralysis, areflexia, various sensory defects, and even deformations of the lower extremities. They're increasing specific neurological deficits with lesions that are more cephalad until we get to about the upper thoracic to cervical area where there are minimal deficits. There is a genetic predisposition with this and a decreased incidence with maternal periconceptional use of folic acid through 12 weeks gestation. Most, that is greater than 80%, are associated with obstructive hydrocephalus, and this is then caused by the Chiari type 2 malformation due to downward displacement of the hindbrain through the foramen magnum with proximal obstruction and ventricular enlargement. If not treated, the patient would develop signs and symptoms of hindbrain dysfunction, specifically apnea, vocal cord paralysis, stridor, and upper extremity spasticity. The diagnosis is to evaluate for any other anomalies, to evaluate urological function, again, like with an meningocele. The MRI of the area is the best test, and the CT for the head for associated Chiari type 2 and hydrocephalus needs to be done. The meningomyelocele, like the meningocele, needs to be repaired and a VP shunt placed if there's any evidence of hydrocephalus. The bladder needs to be catheterized regularly going forward, and repeat evaluations of renal and urological function needs to be performed. Enemas or suppositories are necessary in the future for bowel dysfunction. Most will have functional ambulation with lower lesions, that is from the mid-lumbar region down, and about half with higher lesions will walk with the use of orthotic devices. Overall, there is a higher incidence of seizures and learning problems in these patients. Hydrocephalus is impaired circulation and absorption of cerebrospinal fluid for whatever reason. There are two types. The most common is obstructive or non-communicating. These represent congenital or acquired lesions within the ventricular system, which then cause the problem with circulation of CSF. And because of this, there's proximal ventricular enlargement. Most commonly, it's at the level of the aqueduct or the fourth ventricle. For instance, there's a congenital lesion of aqueductal stenosis, which can be inherited as an X-linked trait or can occur from gliosis, that is acquired from infections like meningitis or a subarachnoid hemorrhage or even an intrauterine viral infection. Also, a large cause in the preterm infant is intraventricular hemorrhage, may also occur with neurofibromatosis type 1. In the posterior fossa, we have a higher incidence of brain tumors causing this, and the uncommon Chiari type 1 malformation, which occurs primarily in an adolescent or adult presenting with headache and progressive lower extremity spasticity, usually without hydrocephalus. And as we said, type 2 malformation and the Dandy-Walker malformation, which we'll talk about momentarily. Non-obstructive or communicating represents obliteration of the subarachnoid cisterns or malfunction of the arachnoid villi, leading to impaired absorption of CSF. This is most common after subarachnoid hemorrhage, leukemic infiltrates, intrauterine infections, tuberculosis, or pneumococcal meningitis. The clinical findings are mostly in infants, where they will present with a rapidly increasing head circumference, bulging anterior fontanelle, distended scalp veins, broad forehead, and the setting sun sign, where the eyes just spontaneously slowly drift downward. There's also increased deep tendon reflexes, a clonus, a positive Babinski sign, and spasticity. Diagnosis is more difficult in older children due to fused sutures. They may just present with findings that are nonspecific, such as irritability, lethargy, vomiting, headache, personality changes, decreased school performance. However, on physical exam, we would see papilledema, pyramidal tract signs, and third and sixth nerve palsies. In the infant with open fontanelles, the diagnosis is usually made with ultrasound through the anterior fontanelle. Serial ultrasounds can follow the progress of intraventricular hemorrhage in a preterm infant. Better diagnosis of the brain and related problems is with the best study, which as usual for the brain is an MRI. Treatment again is with a ventriculoperitoneal shunt. Once a VP shunt is placed, there are always potential problems with occlusion and infection especially from coagulase negative Staph aureus. And there's also, with a VP shunt for any reason, increased incidence of developmental delays, decreased cognitive development, poor memory skills, and visual and behavioral problems. The Dandy-Walker malformation is a specific problem representing obstructive hydrocephalus. This is cystic expansion of the fourth ventricle due to the lack of formation of its roof during embryological development. They are going to present with hydrocephalus, cerebellar hypoplasia to some degree, agenesis of the cerebellar vermis. And infants will have large heads and prominent occiput with cerebellar signs, long tract signs, and significant delays in motor and cognitive development. The lesion is transilluminatable, so it's transillumination positive, and the best test again is an MRI, in which case we can see a large cystic cavity and expansion of the lateral ventricles because the cystic cavity is not in communication with the ventricles proximally, and so there is lateral ventricular enlargement as well as this large cystic space in the posterior part of the brain. The treatment is with shunting of both the cystic cavity and the placement of a shunt in the lateral ventricle. A vignette. An 18-month-old child is brought to the emergency room after having a generalized tonic-clonic seizure that lasted approximately 5 minutes. The parents say that the child has been previously well but developed cold symptoms earlier today with a temperature of 39 degrees centigrade. A simple febrile seizure is defined as a generalized seizure lasting less than 15 minutes, occurring once in a 24-hour period, compared to a complex simple febrile seizure, which is longer than 15 minutes focal and may occur more than once in a 24-hour period. With a simple febrile seizure prior to the onset, the child has a normal history with no evidence of CNS infection or metabolic disturbance. The age is 6 months to 5 years. There is a high rate of recurrence, especially if the first seizure occurs at under 12 months of age, but there is no long-term risk for any sort of problems, and therefore simple febrile seizures are benign events and almost all have a good prognosis. Studies clearly show there is no long-term benefit in anticonvulsant use. In addition, there is no decrease in recurrence risk in the absence of anticonvulsants. That is, regular or intermittent use of antipyretics have not shown to be beneficial, and in fact there may be significant adverse effects of increased or prolonged dosing, and therefore the rule is no long-term treatment of any form is recommended. If there is significant parental anxiety with non-treatment, and this may often be seen, then intermittent oral diazepam at the onset of the fever may prevent a seizure, but this is certainly not warranted routinely. So, in the vast majority of children, no laboratory studies should be done. However, we could consider doing a lumbar puncture with the first febrile seizure in a very young child, that is, in a child under 12 months of age, and certainly when there are any clinical signs and symptoms of meningitis, and in the child under 12 months of age, then these signs and symptoms may not be as obvious. There is an increased likelihood of a CNS infection as the cause of the fever, and therefore the seizure, if the child is still seizing on arrival to the emergency room with a focal seizure or with abnormal neurological findings on examination. We should also consider a lumbar puncture for the first seizure if it occurs between the age of 12 to 18 months and should not be routine then if the child is greater than 18 months of age, only then if the signs and symptoms suggest the diagnosis. Therefore, in terms of the use of the lumbar puncture, we should do it any time we are not sure, particularly in a young child, whether or not meningitis may be present and be causative. EEG is not predictive and should not be performed at all. There's no benefit of obtaining any form of routine blood studies and no routine neuroimaging. A simple partial seizure is a relatively short focal, that is asymmetric, tonic or clonic seizure without any loss of consciousness. Some might have a vague aura, but generally they remain awake and can talk during the seizure, and there is no postictal period. The EEG will show unilateral, bilateral, or multifocal spikes or sharp waves. Principal treatment is with a number of different drugs, particularly the drugs of choice are carbamazepine or phenytoin. A complex partial seizure, however, is a focal seizure that may begin as a simple partial seizure, but there is some degree at some point of loss of consciousness, or the loss of consciousness may occur from the beginning. We also commonly see with this lip smacking, salivation, walking, running, and other behavioral automatisms. They can become secondarily generalized. Usually they last a little longer than simple partial seizures, and there is a postictal period. The EEG shows anterior temporal lobe sharp waves, or focal or multifocal spikes, and we may see this on the interictal EEG, but depending on when the EEG is performed in relationship to the end of the seizure, it may be normal, and other specialized EEG methods may be needed to demonstrate abnormal electrical activity. Generally, we will do a CT or the best study, the MRI, to look specifically at the pathology of the temporal lobe, which of course should be present in this. Principal treatment, again, is primarily with carbamazepine or phenytoin, less commonly with other anti-seizure medications. There are three basic types of generalized seizures. The first is an absence or absence seizure, also called petit mal. The child will have the sudden cessation of motor activity or speech with a blank facial expression and at most some eyelid flickering. It's most common in girls between 5 and 8 years of age. The total duration is usually quite short, with the then resumption of pre-seizure activity. There's no aura or postictal state. They may have automatisms, these strange behaviors described previously, and they may have multiple seizures in a 24-hour period. The EEG will show a 3 per second spike in generalized wave discharge. The principal management is with ethosuximide first and valproic acid second. Generalized tonic-clonic seizures, the overall most common form of seizure that we see, may present from the outset or follow a partial seizure, as I said previously. The activity may be preceded by an aura, which typically represents the focal site of origin of the seizure. There's generally sudden loss of consciousness with the eyes rolled back, then tonic contractions, some degree of cyanosis and apnea, followed by the typical rhythmic clonic contractions, and then a gradual slowing. Patient may bite the tongue, vomiting is rare, and there is usually loss of sphincter tone, especially the bladder. What follows is a significant postictal period, then deep sleep with subsequent vomiting and bifrontal headache. This is the typical presentation. The EEG has variable findings. Principal management, again, is with a variety of anticonvulsants, including phenobarbital, primidone, phenytoin, carbamazepine, valproic acid, and more. There are several types of myoclonic seizures, from benign to very severe. Benign myoclonus of infancy are clusters of myotonic movements, that's brief symmetric muscle contractions, mostly of the neck, trunk, and extremities, and this is quite normal. It is very common, and they typically stop by age 2 without any interruption of normal development. In other words, the infant is absolutely fine. If the EEG is done because it's not recognized, it's completely normal, and there is no management of this. On the other hand, myoclonic epilepsy of early childhood are also repetitive myoclonic movements that may occur multiple times in a day. However, they may be preceded by tonic-clonic seizures. The onset is usually in the first years of life. Some have a positive family history of seizures, and the prognosis in most is good, although they may have some learning problems, and a very small number have mental retardation. The EEG will show typically fast spike waves of greater than 2.5 hertz with a normal background, and the principal management is valproic acid and others less commonly. Infantile spasms are a form of juvenile myoclonic epilepsy. They are brief symmetric contractions of the neck, the trunk, and the extremities with typical clusters over minutes at a time. They will usually start at 4 to 8 months of age, and most are associated with specific problems. That is, prenatal problems, perinatal or postnatal, and the majority have a very poor prognosis, mental retardation and specific neurological dysfunction. The major association of infantile spasms is with tuberous sclerosis. The few that have no obvious previous problems have a good prognosis. The underlying issue is felt to be due to overproduction of corticotropin-releasing hormone, which then leads to neuronal hyperexcitability. The EEG typically shows what is called hypsarrhythmia. This is a chaotic, high-voltage, bilaterally asynchronous slow-wave activity EEG. Because of the corticotropin-releasing hormone being high, as stated, the first principal management is with ACTH, and then the addition of other anticonvulsants, which are typically necessary to get control of the seizures, and then it is difficult even with that. Neonates have seizures, and they are at increased risk for seizures, but do not commonly have generalized tonic-clonic seizures because of decreased arborization and myelination. Typical seizures include focal, multifocal, tonic, and myoclonic, but the vast majority will have what we call subtle seizures, where unless you think about it, it may not clearly look like any form of seizure. These include behaviors such as chewing, salivation, apnea, blinking, perhaps just color changes, or what is known as bicycling, where it actually looks like the baby who is in the supine position is trying to ride a bicycle. So subtle seizures may be difficult to detect, but they can also be associated with autonomic changes, changes in the heart rate, in the breathing, and blood pressure. Generally, you do not get lack of suppression with general restraint as opposed to myoclonic jerks, and there's no effect of sensory stimuli on the activity. The most important cause is hypoxic ischemic encephalopathy. That is, some reason to have a decrease in brain blood flow and oxygenation in the perinatal period, typically during labor and delivery. But we always need to consider the other possible findings, including infection, whether it's sepsis or meningitis, metabolic causes, particularly with respect to glucose and calcium, acid-base disorders, or much less commonly, and at the end of the list, inborn errors of metabolism, also from birth trauma, hemorrhage, structural abnormalities, and certain maternal conditions like illness, drugs, or medications, or treatments like accidental injection of lidocaine into the fetus during delivery. So all of these possible causes need to be taken into consideration with the neonate with seizures. Infection should be evaluated with a CBC. Cultures, prophylactic antibiotics are started. Electrolytes are obtained, again, most importantly, glucose, calcium, and even magnesium. A CT is often performed automatically for structural abnormalities, for the possibility of trauma, particularly with a hemorrhage, and then other workups less commonly. At the end of the list, as I said, workup for an inborn error of metabolism. Treatment is primarily with lorazepam and phenobarbital. Vignette. A 6-year-old presents to the pediatrician for a routine evaluation. Child is noted to have 10 cafe au lait lesions as well as axillary freckling. Neurofibromatosis type 1 is also known as von Recklinghausen disease. It is an autosomal disorder with half presenting as new mutations and a high penetrance rate, so there are carriers with clinical findings. The specific mutation is known, and it is on chromosome 17, but there's a wide range of mutations which result in the decreased function of the protein neurofibromin. Genetic testing may be performed. Prenatal diagnosis may be made if one parent has been diagnosed with the disease. Features may be present at birth or any time later in life. The diagnosis is a clinical diagnosis based on finding at least 2 criteria. No routine neuroimaging is done for diagnosis and no other laboratory studies are necessary. So we have the following list to choose from. Cafe au lait spots, hyperpigmented lesions, these are usually the first feature, and they may be present at birth or occur in infancy. An increase in size and number is typically the rule that occurs throughout childhood. Second, a pathological feature is the neurofibroma. This can present in all organ systems. They appear on the skin most commonly prior to puberty and present to some degree in all by adulthood. These are nodules or tags sometimes in the skin, deeper tissue, or subcutaneous tissues. They also increase in size and number with puberty and with pregnancy, but tend to be intermittent throughout life. There's another form of neurofibroma called a plexiform neurofibroma, which is usually congenital. This is a soft tissue enlargement or patch of hyperpigmentation with or without hyperkeratosis. Thirdly, an osseous abnormality may be found. The most common in neurofibromatosis is scoliosis, but this is hardly diagnostic. Tibial dysplasia is diagnostic, that is, cortical thinning of long bones, particularly in the lower extremities and the tibia. When it is present, it occurs at birth, and there's an increased risk with walking of fractures. Also diagnostic is sphenoid dysplasia, of which a radiographic study would disclose. Fourth, axillary or inguinal freckling. These are freckles similar to facial freckles, most commonly seen at ages 3 to 5 years of age, and in the majority of patients with neurofibromatosis, and is the second most commonly noted feature of this disease. Fifth, the optic glioma. This occurs in about 15% of all patients, and it is the most common CNS tumor. It develops in children typically under 6 years of age. There may be visual loss, proptosis, and even precocious puberty if the optic chiasm is involved, but many children will have no symptoms unless the tumor becomes significantly larger. Symptomatic lesions are treated with various drugs before the possibility of surgery. A routine yearly eye exam should be performed in every patient. And finally, Lisch nodules, which are iris hamartomas. These occur beginning in early adolescence and are only a marker. They do not cause clinical problems. About 1/3 of all patients develop serious complications. There is an extreme degree of variability within each family. Most are mildly affected, and we cannot predict any significant complications in childhood going forward. The most important thing is an increased risk of lifelong malignancy. Most common are peripheral malignant sheath tumors, which present as pain and increased growth of a plexiform or deep nodular neurofibroma. Other tumors include abdominal tumors such as pheochromocytoma or Wilms tumor. There's also an increased risk overall of various forms of rhabdomyosarcomas, increased risk of leukemia, vascular tumors, and particular any type of brain tumors, and any of these can be the cause of death. There's also an increased risk of gastrointestinal neurofibromas, which can cause all sorts of problems. Seizures in this disease occur in less than 10%, and most of them are not related to any specific etiology. We can have non-ossifying fibromas of the long bones, especially in the lower extremities, progressive kyphoscoliosis with the secondary development of pulmonary dysfunction. Essential hypertension is the most common form of hypertension, but we can also have renovascular hypertension or hypertension secondary to specific tumors or even coarctation. There's an increased incidence of mental retardation. In fact, most have average to low intelligence, and they have specific learning disabilities as well. There's poor fine motor coordination and other neurological problems like decreased tone, balance, and gait abnormalities and speech problems, and a significant increase in the incidence of ADHD. With respect to management issues, we typically will evaluate clinically for new neurofibromas and progressions of lesions. Otherwise, there's no routine diagnostic studies or imaging without any specific positive signs and symptoms. A yearly blood pressure needs to be done, and this is the case with any child in well child care visit. A careful neurodevelopmental evaluation at each visit needs to be performed, and all neurodevelopmental issues need to be attended to. A yearly ophthalmological exam needs to be performed because of the possible eye findings, and continued evaluation for any possible skeletal changes. Neurofibromatosis type 2 is diagnosed with either bilateral eighth nerve acoustic neuromas on CT or MRI, or with a parent or sibling with a diagnosis and either unilateral eighth nerve masses or at least two of the following findings: subcapsular lanopacities, one or more neurofibromas, a meningioma, a glioma, or a schwannoma. However, the most distinctive feature, again, is bilateral acoustic neuromas resulting in some degree of hearing loss, and this may be the presenting finding. Vignette: a 1-month-old infant presents with infantile spasms and has hypsarrhythmia on EEG. Tuberous sclerosis is the second of the neurocutaneous syndromes. It is also autosomal dominant with spontaneous mutations and a wide variation within the same family. In general, the younger the presentation, the greater the risk of problems and of mental retardation. The major features are, first, a characteristic skin lesion. The most obvious one, which typically presents in infancy, is the ash leaf macule. For diagnostic purposes, we have to have at least three. They occur on the trunk and the extremities. These are hypopigmented lesions that typically look like the leaf of an ash tree and are better visualized with a Woods ultraviolet lamp. The second two occur most commonly with an older child presentation. The first is the sebaceous adenoma. They will typically develop if present between the age of 4 to 6 years of age and are usually small red nodules over the nose and the cheeks that later coalesce and enlarge. The second lesion, then, of more commonly the older child, is the shagreen patch, which is a rough, raised lesion that looks like an orange peel, especially in the lumbosacral area. The pathological lesion is the tuber. This is decreased neurons with astrocytes and multinucleated giant neurons. An increasing number corresponds to increasing neurological impairment. They will occur in the cerebral convolutions and project into the ventricular system. They typically become calcified over time and can be a cause of obstructive hydrocephalus. In general, brain tumors are less common than found in neurofibromatosis type 1. The most common and most significant ongoing neurological problem is a seizure disorder, but cognitive impairment also occurs along with behavioral abnormalities, including autism. The presenting seizure in infancy is the infantile spasm. As we said, these are difficult to control. They can even further develop into myoclonic seizures, and there's often severe cognitive and neurobehavioral impairment. The most common seizure when the disease presents in an older child are generalized seizures. The eye lesions are primarily retinal, and these can be Mulberry-type tumors from the nerve head in the retina to disc lesions, hamartomas, or abnormal pigmented areas. But also, we have tumors in the heart, in the kidneys, or the lungs. In fact, half of the patients have a rhabdomyoma of the heart, which tend to resolve slowly, but they may cause arrhythmias or even heart failure. The kidneys are affected in most after 10 years of age with various problems, and the lungs become affected with lymphangiomyomatosis, and this produces a restrictive lung disease pattern with age. When the diagnosis is made clinically with the previous mentioned criteria, we'll typically obtain either a CT or MRI. MRI, of course, would be the best test. Renal ultrasound is done automatically because of the high incidence of renal problems. And also, for the same reason, with respect to the cardiac rhabdomyoma, a cardiac echo is performed and a chest x-ray is done because of pulmonary findings. Repeat studies then are done only with specific signs and symptoms, as is the case with neurofibromatosis 1. Any evidence of increased intracranial pressure requires immediate investigation for possible surgery because of the CSF obstruction or mass lesions. Management issues are the same as with NF1. The most important treatment issue is control of seizures, again, which may be difficult. A vignette. A newborn examined in the nursery by the pediatrician. Patient is a product of a term spontaneous vaginal delivery without complications. On physical exam, patient is noted to have a facial port wine nevus. Sturge-Weber syndrome occurs with a sporadic presentation. This disease represents abnormal development of the primordial vascular bed in early stages of cerebral vascularization. The brain becomes calcified and ultimately atrophic. The most important clinical feature is the nevus, the port wine stain, and this is always present at birth. It's unilateral on the side of the abnormal brain development and always involves the forehead and the upper eyelid. Not all congenital port wine stains are, however, due to Sturge-Weber syndrome. Also, ipsilateral glaucoma would be present. Seizures occur in the first year of life, which tend to be focal tonic-clonic seizures, and on the opposite side of the nevus and the abnormal brain development, and also, of course, the glaucoma. And the seizures will quickly become refractory. Hemiparesis slowly develops. Later, there are severe learning disorders and mental retardation. For babies then presenting with a port wine nevus at birth, a skull film in patients with Sturge-Weber will show the beginnings of calcification, which are in the occipital parietal area on one side, and typically present as two linear areas next to each other, parallel to each other, producing a so-called railroad track appearance. Further delineation can then be done with a CT scan, which will show calcifications and ultimately unilateral atrophy, and because of the atrophy, expansion of the ventricular system, which we call hydrocephalus ex vacuo. The best study would then be the MRI for exact size and location of vascular malformations and any white matter lesions. The most important management issue, again, is seizure control. We also need to manage behavioral and learning problems. Special education is usually necessary, and the usual surveillance of complications with no routine studies unless signs and symptoms are present, except for the routine evaluation of intraocular pressure. If seizures do become refractory, it's generally in the first 2 years of life, and unfortunately because of this, the treatment of choice is hemispherectomy. The port wine stain can be diminished significantly with pulsed dye laser therapy. Cerebral palsy is the most common chronic motor disability that starts in childhood and can occur from any one of a number of disorders representing abnormalities of early brain development. The features can change over time, and there can also be abnormalities of cognition and speech, sensory abnormalities, feeding and behavioral problems, and some may even have a seizure disorder. In some cases, specific antenatal factors resulting in abnormal brain development can be identified. But it's important to realize that under 10% are associated specifically with perinatal asphyxia. In fact, most are born at term without any problems during labor and delivery at all. There's a significant increase, and the strongest correlation then is with low birth weight infants, especially the very low birth weight infants, and with antenatal intrapartum maternal infection. Most of the very preterm infants who ultimately are diagnosed with cerebral palsy are due to large intraventricular hemorrhages with periventricular leukomalacia, that is, infarction and cerebromalacia of the white matter around the lateral ventricles where we have the beginnings of the motor long tracts. In fact, if we have an MRI at 40 weeks postmenstrual age in a preterm infant that shows white matter abnormalities, this is the most highly predictive finding of ultimately making the diagnosis of cerebral palsy at 2 years of age. There are 4 types of cerebral palsy depending on the features. The first is spastic hemiplegia. This is most commonly due to an in utero or neonatal stroke because of any one of a number of thrombophilic conditions. What we see here is decreased movements on one side. The upper extremity is affected more than the lower extremity. Early hand preference, difficulty with hand use, growth arrest, especially of the hand more than the foot, delayed walking, and then abnormal gait. Spasticity is the hallmark with toe walking, and there's other upper motor neuron findings, including increased deep tendon reflex, clonus, and extensor plantar responses. The MRI will ultimately show atrophy of a cerebral hemisphere with hydrocephalus ex vacuo. The second type is spastic diplegia. This is most commonly caused by periventricular leukomalacia, where there's bilateral spasticity of the legs more than the arms. Spastic quadriplegia occurs from multicystic problems in the cerebral hemisphere, periventricular leukomalacia, and various malformations. All extremities are involved with hypertonicity and spasticity and decreased movement, sometimes with athetosis. And finally, the extrapyramidal type is called the chorioathetoid type. This is most likely associated with asphyxia, kernicterus, certain genetic and metabolic problems. In these patients, there's initial hypotonia, poor head control with persistent head lag, and then a variable increase in tone with rigidity and dystonia over years. The diagnosis is made by history and physical, including a thorough neurological and ophthalmological exam, to exclude any neurodegenerative disease, metabolic disorder, spinal cord abnormality, or muscular dystrophy. So we also need, in conjunction with this differential diagnosis, blood chemistries, acid-base analysis, glucose, liver and renal function, urinalysis. The most important study is the MRI of the brain and spinal cord to look for any structural lesions and to look for the effects of hypoxic ischemia. We also test hearing and vision, and genetic evaluation and counseling for the family is necessary. Management is by a multidisciplinary team which involves neurology, orthopedics, physiatry, psychology, and dentists. Various therapies are performed: physical therapy, occupational therapy, speech therapy, feeding therapy, and developmental therapy. Daily activities need to be taught and how best to function and play. Therapy only optimizes function. Children and families are taught in terms of the use of adaptive equipment. Prevention of contractures is necessary. Improvement of communication skills with the use of special equipment. Management of eye and hearing disorders, behavior management, management of learning and cognitive disorders. And surgical procedures are also used to decrease muscle spasms, and certain spasticity drugs like baclofen, dantrolene, and botulinum toxin are sometimes used when severe spasticity has not improved with some of these other therapies. Next, we'll talk about some of the neurodegenerative diseases which are more likely to appear on this exam. The first is Friedreich ataxia. This is an autosomal recessive abnormality of the gene coding for mitochondrial protein frataxin. This then causes oxidative injury due to excessive mitochondrial iron deposits. It primarily affects the spinocerebellar tracts, the dorsal columns, the pyramidal tracts, cerebellum, and the medulla, so that what we see is a slowly progressive ataxia before the age of 10 years of age, with involvement of the lower extremities primarily, and then gradual weakness of hands and feet, dysarthria, loss of deep tendon reflexes, loss of vibratory and position sense, nystagmus, and an extensor plantar response. Key in the diagnosis is progressive kyphoscoliosis as well as other skeletal problems, and progressive hypertrophic cardiomyopathy, which is the usual cause of death. Symptomatic treatment and the use of antioxidants will, in some cases, slow the progress somewhat. Otherwise, there is no effective therapy. Wilson disease is pathologically hepatolenticular degeneration. There's degenerative changes in the liver, the kidney, the brain, and the cornea. It is an autosomal recessive disease. The problem is the gene encoding for copper transporting ATPase, which is critical for biliary copper excretion. The abnormality leads to progressive diffuse accumulation of copper in the hepatocytes, which will eventually fibrose, and then the copper spills out into other tissues. Most patients are compound heterozygotes. If there's no gene function, then the disease begins at about 2 to 3 years of age. But there are milder mutations, and they are therefore associated with a later onset, even into adulthood. Younger children primarily present with liver signs and symptoms like hepatosplenomegaly, subacute or chronic hepatitis, fulminant hepatic failure, or other hepatic dysfunction. In fact, we are taught that we always must think of this diagnosis in any child with unexplained liver disease. Older patients primarily have neurological symptoms, particularly intention tremors, decreased coordination, abnormalities of tone, speech problems, and even behavioral and psychological changes such as decreased school performance. The Kaiser-Fleischer ring is pathognomonic. These are golden rings in Descemet's membrane of the cornea, seen with a slit lamp examination, and they will always be present with the onset of any neurological or neuropsychiatric changes. We can also see other findings such as a Coombs negative hemolytic anemia, the renal Fanconi syndrome, and ultimately progressive renal failure. The best initial test is serum ceruloplasmin, which will be decreased because of the failure of copper to be incorporated into it, and so there is decreased production of ceruloplasmin. This then results in increased serum copper and increased urinary excretion of copper. This is also seen in family members. The most accurate test is to perform a liver biopsy for copper content. Genetic diagnosis can also be made. The first part of the treatment is to decrease copper intake and to use D-penicillamine to chelate the copper. The long-term therapy is a liver transplant with progressive disease, which will typically occur in any patient at some point in their lives. Metachromatic leukodystrophy is a rare disease caused by a deficiency of aryl sulfatase A. As a result, there's an accumulation of sulfated glycosphingolipids in all neural white matter, which leads to demyelinization and then neurodegeneration. Most present in the first or second year of life with no walking, knee hyperextension, little or no deep tendon reflexes, diffuse hypotonia, and then gradual muscle wasting. Then they develop nystagmus, loss of any speech which may have developed previously, loss of hearing, myoclonic seizures, ultimately quadriparesis and optic atrophy. Death occurs in the first 10 years of life. Laboratory studies show increased CSF protein, metachromatic granules in the urine sediment, and the MRI shows diffuse symmetric attenuation of white matter. If we stain a histological section of the peripheral nervous system, we will find differential staining, that is metachromatic neural inclusions that represent sulfite granules that stain positively. For instance, with cressyl violet acetate, the overall color of the section is purple. However, the sulfite granules will stain brown. Hence, we have dual staining from, in this case, a purple stain, and hence the name metachromatic leukodystrophy. There's no cure for this, and all patients die typically at a young age. There are various forms of adrenal leukodystrophy. These are the only neurodegenerative diseases that are X-linked recessive. They result from accumulation of very long-chain fatty acids in neural tissues and in the adrenals, presenting then as adrenocortical insufficiency. Most common findings beginning between 5 and 15 years of age. The earliest problems are neurobehavioral, decreased school performance, behavioral changes, and then neurological findings such as gait disturbance, generalized seizures, upper motor signs, ataxia, and pseudobulbar palsy. The Addisonian type of disease, the adrenal insufficiency, can precede the neurological findings in about half of the patients. An MRI shows periventricular demyelation beginning posteriorly and progressing anteriorly, and death usually occurs within 10 years of the onset unless a bone marrow transplant is done, or if a mixture of glycerol trioleate with glycerol triauricate, which now is known as Lorenzo's oil, is given prior to the age of 6, or with any start of MRI changes. Tay-Sachs disease, along with Sandhoff disease, are the two major GM2 gangliosidosis. The deficiency in Tay-Sachs is beta-hexosaminidase A only, and so we have accumulation of lysosomal GM2, especially in the central nervous system. The predilection is in Ashkenazi Jews. The key features of Tay-Sachs are an infant with motor loss, hyperacusis with an increased startle response, macrocephaly but no hydrocephalus, and a classic macular cherry red spot. We also have seizures and progressive neurodegeneration with death typically prior to age 5 years of age. Lesch-Nyhan disease is an X-linked disease of purine metabolism, so we will see this primarily in boys. The defect is HGPRT deficiency, that is hypoxanthine phosphoribosyl transferase deficiency, and therefore will have an increase in deposition of hypoxanthine and of uric acid. The presentation begins in early infancy with the development of global developmental delay, mental retardation, and severe lack of speech development with dysarthria present. The primary neurological findings are chorea, dystonia, hypotonia, and most importantly, evident for the diagnosis is self-injurious behavior with biting of the fingers and the lips, short stature, and evidence of hyperuricemia, primarily with arthritis, soft tissue tophi, and renal calculi. When you put all of this together, the diagnosis is relatively straightforward and can be proven with evaluation of the enzyme. Treatment is only supportive. There is no cure. Behavioral modification is used. The management of complications, particularly with respect to uric acid. Teeth often need to be pulled because of self-injurious behavior. And again, if this is significant, the patient needs to be restrained and given anxiety drugs to reduce anxiety and drugs to stabilize the mood. The spinal muscular atrophies are a group of diseases that result from progressive denervation of muscle with subsequent atrophy due to continuation of the normal process of programmed neuronal cell death through the perinatal and postnatal period. Normally, the survivor motor neuron gene, the SMN, arrests this process after a certain point, and it is mutated in the SMAs. Most are autosomal recessive, and it's seen in all ethnic groups. Type 1 SMA is also sometimes called, or used to be called, Verdnick-Hoffman disease. This is the severe infantile type that will present with severe hypotonia, weakness, and decreased muscle mass over the first months of life. Eventually, there will be no deep tendon reflexes. Fasciculations will be present, which can most easily be seen in the tongue, and then also the face and the jaw, and eventual involvement of the diaphragm will occur. As a result of this, there will be decreased feeding, decreased movement, lack of head control, increasing flaccidity, and then finally respiratory weakness and distress. The vast majority will die in the first 2 years of life. SMA type 2 is the late infantile type and actually is the most common. Here there's a progressive weakness and scoliosis through the earlier school years, sometimes often later, and they become wheelchair dependent. And the third form, SMA3, is the juvenile type, which is also called Kugelberg-Wieslander disease. This is progressive weakness in the proximal muscles, especially the shoulders. They remain ambulatory for most of their life, and certainly at least into middle adulthood. The best test is to obtain blood for the genetic evaluation of the SMN gene. Muscle biopsy, which usually is not necessary, shows nonspecific findings of denervation atrophy. The electromyogram, EMG, also is not necessary anymore. It shows nonspecific signs of denervation and fibrillation potentials. Nerve conduction velocity, of course, would be normal because this is not a peripheral neuropathy. And we also have a mild nonspecific increase in creatinine kinase, CK. There's no cure. Nothing will delay the progression, and therefore treatment is entirely symptomatic. Vignette: a pediatrician examines an infant with poor sucking and swallowing since birth. The infant is noted to be a floppy baby with poor head control. There's associated ocular ptosis and weak muscles on repeated use. Myasthenia gravis is rapid fatigue of striated muscles from immune-mediated neuromuscular blockade. This results in decreased acetylcholine receptors because there are circulating receptor-binding antibodies, which leads to decreased responsiveness of the motor end plate. Most cases are not hereditary, but there are familial non-immune forms, and there's also an association with Hashimoto thyroiditis and collagen vascular disease. In the most common form, the juvenile form, we typically see ptosis and some degree of extraocular muscle weakness as the first sign. Also early on may be the possibility of poor head control, dysphagia, facial weakness leading to feeding problems. Most will have involvement of the limb girdle and distal muscles of the hand. Fatigue occurs late in the day or when tired due to rapid fatigue of muscles with repetitive or sustained contractions. If untreated, it may lead to respiratory failure. The EMG, electromyogram, is specific for the diagnosis, which shows decreased response to repetitive stimuli until the muscle is refractory. And then this process is reversed after administering a cholinesterase inhibitor. Again, nerve conduction velocity is normal. There's no reason why it should be abnormal. And anti-acetylcholine antibodies may be found or not, so they are an inconsistent finding. The test primarily then is to administer edrophonium which is called the tensilon test. It's a short-acting cholinesterase inhibitor, and the findings, primarily ptosis, ophthalmoplegia, and fatigability of other muscle groups, then improves after administering the drug within a few seconds. Mild disease may require no therapy at all. Otherwise, cholinesterase inhibitors are the primary therapy. This can either be neostigmine methyl sulfate intramuscularly or oral neostigmine bromide or pyridostigmine. Pyridostigmine requires a greater dose, but it has a slightly longer half-life. Too great a dose can result in a cholinergic crisis. If there's no response, which is possible if there are large antibody titers present, then prednisone, IVIG, or plasmapheresis may be effective. A potential complication is patients do not tolerate neuromuscular blockade during anesthesia, whereupon they may have paralysis for a week. Also, aminoglycosides can potentially increase the blockade and should be avoided. The disease may undergo spontaneous remission or persist into adulthood. There are a number of identified hereditary motor sensory neuropathies, HMSNs, but type 1, which is Charcot-Marie tooth disease, is by far the most common, and this leads to peroneal muscular atrophy. This is the most common genetic neuropathy. Most are autosomal dominant with a high degree of expressivity. Most patients are asymptomatic until later in childhood to adolescence, when the peroneal and tibial nerves are involved first. This leads to a very slow, gradual wasting of the muscles of the anterior compartment of the lower leg. So children are often described as clumsy because they fall frequently. Muscle wasting is then progressive, and eventually there's a clear difference with the muscles above the knee versus those below, and the patient is said to develop a stork-like appearance. At this point, the patient will also have foot drop with foot arch abnormalities, and most require assistance from orthotic devices. The forearms may be involved, so that there can also be, in the worst forms, atrophy of the muscles of the forearms and hands, and this may lead to a claw-hand deformity. The most important initial step is to perform a nerve conduction velocity, which will show slowing. There's no need for an EMG or muscle biopsy. Sural nerve biopsy is diagnostic and shows a particular pathology, which is interstitial hypertrophic neuropathy. The definitive diagnosis can also be made with molecular genetics. The basis of treatment is to stabilize the ankles with orthotic devices, to use physical therapy, splinting, protect the legs and knees from trauma, and, if necessary, surgical ankle fusion. Sometimes patients may have sensory deficits, most commonly burning paresthesias, and these can be treated with particular anticonvulsant drugs. No treatment delays the progression of the disease. Guillain-Barré syndrome is mostly a post-infectious polyneuropathy, usually occurring after a non-specific viral illness in children after about 10 days. However, it is especially associated with Campylobacter jejuni and Helicobacter pylori. It can also occur after a rabies vaccine, influenza vaccine, and oral polio vaccine, which is no longer available in the United States. The clinical findings usually begin with lower extremity weakness, which progress cephalad to the trunk, the upper extremities and bulbar muscles. This is called a Landry ascending paralysis. You can also have initial sensory involvement, so that patients report tenderness and paresthesias on palpation of the muscles, and then they may have flaccid paralysis of all four extremities. A bulbar involvement is a sign of impending respiratory failure. Deep tendon reflexes are lost early. You can also have involvement of the autonomic nervous system, including lability and blood pressure, a cardiac rate, and even the possibility of asystole. Small numbers of patients have acute relapses during the recovery phase, and some have a chronic relapsing form over months to years. The most important test, and usually the only one that is necessary, is the lumbar puncture, which shows that the CSF has a dissociation of protein in cells. That is, there's an increase in the CSF protein with a normal glucose and nucleocytosis, and of course the culture will be negative. There's greatly reduced motor, sometimes sensory nerve conduction velocity, and there may be positive anti-ganglioside antibodies. All children need to be admitted in the early stages for observation, particularly with respect to respiratory compromise. Slowly progressive disease, however, can be observed and just utilize symptomatic treatment. Rapidly progressive disease is treated with IVIG. If this is ineffective in rapidly progressive disease, then plasmapheresis and or immunosuppressive drugs are given, or sometimes IVIG with the use of interferon. Vignette: a 3-year-old boy is brought to the pediatrician because the patient is very clumsy. According to the young boy's parents, he's having difficulty climbing stairs and frequently falls. On physical examination, hypertrophy of the calves is noted. Duchenne and Becker muscular dystrophies are the most common primary hereditary myopathies on a worldwide basis. Becker is essentially the same as Duchenne, but in a milder, more protracted form. All races and ethnic groups around the world have been found to have this disease. Most are X-linked recessive, and up to a third are new mutations without female carriers. The pathology is a significant decrease in muscle dystrophin. The clinical presentation varies widely. Initially, in some cases, infants may be found to be mildly hypotonic with poor head control and have a delay in motor skills. Possible hip girdle weakness can be seen as early as 2 years, with lordosis prominent by age 3 years and progressive thereafter. By 3 to 6 years, consistently is a hip waddle while walking and the presence of the Gower sign, which occurs when we have the child sit on the ground and ask them to get up quickly. They can't do this easily, and so they first have to roll into the supine position and then the prone position, eventually get on hands and feet, put their hands on the ground and push first one hand to a leg and then use the leg to push the other hand up to the other leg and slowly climb up the legs with their hands until standing. Calf pseudohypertrophy may also be evident. In this case, muscle is replaced with fat and collagen. And most patients will have the ability to walk without orthotics until about 10 years of age, and then with orthotics until about age 12, and then they are wheelchair dependent with a rapid progression of scoliosis, thoracic deformities, and contractures, and then progressive weakness of respiratory muscles with subsequent increased infections, decrease in pulmonary function, and gradual loss of deep tendon reflexes. The standard of care is to first screen with a serum CK. The normal value is up to 160 international units per liter. In muscular dystrophy, it will be 15 to 35,000. A normal value, of course, is not consistent with the diagnosis. The specific diagnosis can then be obtained first with a PCR of a blood sample for the dystrophin gene mutation, but 1/3 are falsely negative due to several reasons with respect to the genome and testing methodology. In this case, then, the next step, which happens to be the most accurate study, needs to be performed, which is a muscle biopsy. Because this is more invasive and not always necessary, it's not done initially. And we do this with specific immunochemical studies for the abnormal dystrophin protein. EMG is nonspecific, and it shows nonspecific myopathic features, which is not a diagnostic. Based on the presentation and the fact that cardiomyopathy is present in all, most will die by 18 to 20 years of age, either because of worsening pulmonary disease with respiratory failure and a final infection, or due to severe heart failure. Intellectual impairment occurs in all. Most will have some form of learning disability. There's no cure or slowing of the progressive deterioration. Treatment is supportive with a multidisciplinary team. So again, we have physiotherapy to delay contractures, the use of orthotic device, good nutritional counseling, calcium supplementation to decrease the incidence of osteoporosis. The use of cardiac medications is necessary, such as digoxin, the management of psychobehavioral and adjustment issues, and some studies show that the early use of corticosteroids improves the long-term prognosis as well as short-term improvements.